This video demonstrates retrograde nailing of femoral shaft fractures in a Sawbones model. The entry point is very important. It needs to be center-center on the AP and lateral radiograph, just anterior to the notch. This guide is available in this particular set to center the guide pin in the middle of the femur. It has a suction device attached to it so that debris will not go in the joint. It's better to use the eccentric hole rather than the center hole to maximize the potential for repositioning if the initial pass of the guide pin is not exactly correct. This is demonstrating that the pin is passed parallel to the femur shaft at the top of the notch. If this pin is not exactly right, the guide can be swiveled to get a pin that is exactly in the center on the AP and lateral. An entry reamer is used over the guide pin through the sleeve so that the debris created will not go into the joint but can be sucked out. This entry reamer is also done with the fracture in a reduced position so that eventual position of the nail will hold the fracture in a reduced position. This is in contrast to other techniques where the entry point can be made prior to reduction of the fracture. The reamer should be buried so that the proximal 5 centimeters of the nail is inserted into the bone. The guide pin typically comes out when the reamer is removed. A ball tip guide with a finger device to manipulate the fracture and direct the ball tip across the fracture in an easy manner is available in this set. This is again passed through the sleeve into the reamed hole in the distal femur. The manipulation device can be used to both manipulate the distal fragment relative to the proximal fragment and to direct the ball tip anteriorly, posteriorly, medially, or laterally as needed to pass it across the fracture site. A pistol grip is used to advance the ball tip across the fracture site. The manipulator is removed and the ball tip guide is left in place. It is then advanced up to the base of the lesser trochanter and a length is measured, making sure the fracture is in a reduced position and that the tip of the measuring device is recessed approximately 4 millimeters beneath the articular surface. This is very important because the nail cannot be left long, otherwise it will protrude into the knee joint and cause unnecessary damage. This illustrates how it would be easy to make the nail too long. Standard reaming is then performed, starting with an in-cutting reamer, in this set a 9 millimeter diameter. To show the reamer, we are not demonstrating the use of the sleeve in this case, but in a standard case the sleeve would be used for the reaming as well, so that the debris from the medullary canal is not likely to go into the knee joint. Many sets have a partial circumference sleeve that can also be used during reaming, as illustrated here. Reaming is typically done on full speed spin, slowly advancing the reamer. You do not want to let the reamer pull itself up the femur shaft, otherwise it may become stuck. The advancement should be quite easy. If not, the reamer should be extracted and any bone that's packed into the reamer removed, so that the pressure inside the medullary canal is kept to a minimum. Deep fluted reamers are more effective at that than shallow fluted reamers. 1 millimeter increments in the reamer diameter is utilized until chatter is felt, and then 0.5 millimeter. We typically ream up 1.5 millimeters greater than the diameter of the nail. There is a device to prevent the ball tip guide from backing out as the reamer is extracted. This obturator will fit through the power reamer and also has a blunt end to facilitate keeping the ball tip guide in position. If the ball tip guide does come back across the fracture, it can be reinserted, but this adds time to the case. The nail is mounted to an entry attachment that also provides for distal locking guide. The bow of the nail is anterior to reflect the anatomy of the distal femur. It is inserted into the medullary canal and then advanced with a series of blows to the end of the entry device. The guide for the distal lock is on the lateral aspect of the distal femur. It's important to maintain rotation of both the nail and the femur reduction during insertion of the nail. Once the nail is well past the fracture site, the ball tip guide can be removed to avoid incarceration or advancement. It is important to seat the nail 5 millimeters beneath the articular surface and to make sure that it stays in that position until distal locking is achieved. Here we are illustrating removal of the ball tip guide. There are some systems where an exchange tube and a driving guide is necessary, but most systems allow for direct removal. In this nail, as in most, there are 3 distal locking options. This is the lateral to medial, anterior to posterior oblique. The sleeve is inserted down to bone, and an inner sleeve, the diameter of the drill bit, is inserted. You need to make certain that all of the connections are tight. Otherwise, the guide will miss the hole in the nail. A nail-mounted guide is typically very effective for distal locking with retrograde nails. As the second cortex is penetrated, you can read the length of the screw directly off the drill bit. Again, you need to make sure that the sleeve is all the way down to bone, otherwise the improper length of screw will be measured. It's important not to have the screw extend through the medial cortex very far, or the patient is likely to have irritation symptoms. The inner sleeve is removed, and then the distal locking screw is inserted. This is a captured screw with an internal capture and an internal screwdriver. The captured screw allows for removal and also prevents escape of the screw from the screwdriver and loss of the screw in the soft tissue. This illustrates the internal capture and the internal screwdriver. It's important to maintain position of the nail and reduction of the fracture during these steps so that the nail is not prominent and the fracture reduction is maintained. Once the distal lock is performed, it's not possible to change the position of the nail relative to the distal fragment. To remove the screwdriver, the capture device must be removed. Sometimes a special T-wrench is necessary, to disengage the capture device from the end of the screw. That T device should never be used to attach the capture device, otherwise it will be too much friction. It should only be used for removal. The screwdriver is then removed. The etching illustrates the position of the screwdriver when the screw is seated. A second lateral to medial screw is placed transversely through the middle guide. Again, when the medial cortex is penetrated, length is measured from the silver inner sleeve. An alternative technique is to use a regular depth gauge. This goes to the medial cortex with the outer sleeve all the way down to bone. This can be done through the outer sleeve of the nail system, but we have removed that sleeve in this illustration for better visualization. The transverse screw has been inserted, and now a medial to lateral screw can be placed with the same guide. With this particular set of instruments, 3 turns will partially disengage the distal targeting from the nail. That allows the distal targeting to back up and be flipped over 180 degrees to the medial side. There are tabs in the end of the guide that fit into the end of the nail. Those tabs at 180 degrees are then reinserted, and the threaded guide is advanced 3 turns to lock it back on. This is much easier than trying to reposition totally a distal locking guide, which would be necessary if the guide was removed in complete. The anterior to posterior, medial to lateral oblique distal locking screw is then inserted in the standard fashion using the same sleeve system, drill, depth gauge, and screw insertion. The distal guide is then removed by disconnecting it from the nail. It takes about 10 turns to disengage, and the entire system will then be removed. Inspection of the distal end shows the nail to be nicely recessed with excellent fixation in the distal fragment in this Sawbones model. Proximal locking is typically done in an anterior to posterior direction with a radiolucent drill. A skin incision is made directly over the hole in the nail, and then the near cortex is perforated exactly in line with the hole in the nail. Far cortex is penetrated. Depth gauge is utilized. A 30 millimeter screw is the proper length in almost every case, and we have now gone to using a 30 without the extra step of measuring the depth. This screw is again a captured screw. It's very important in this setting to use a captured screw, otherwise it's very easy for the screw to escape from the end of the screwdriver and be very difficult to extract. These screws have an increased diameter thread at the base of the head, and there's a tendency to underseat the screws. You want to get the head all the way down to the cortex of the bone. This illustrates the nail both inside and outside the Sawbones model with proximal distal locking.